Let's just start. We just start briefly. We just have our tutorial on Neuraxial block. Our tutorial today will be on Neuraxial block. And we're going to just follow this outline. All right, we're going to look at introduction, then we'll look at spinal anesthesia or subarachnoid block, look at coda and epidural anesthesia. All right, so by way of introduction, when we say Neuraxial block, we're actually referring to the trio of spinal anesthesia, also known as subarachnoid block, epidural anesthesia, and coda anesthesia. Coda anesthesia actually is a form of epidural anesthesia. But generally speaking, when we talk about Neuraxial block, we are referring to the trio of spinal, epidural, and coda anesthesia. Advantages of Neuraxial blocks are numerous, but let's just emphasize on the following. One of the advantages is that it decreases stress response to surgery. All right, surgery usually is associated with stress response, but Neuraxial blocks generally reduce the stress response to surgery. Number two, it reduces the incidence of VTE, venous thromboembolic events. Neuraxial block reduces the incidence of venous thromboembolic events. Three, it decreases postoperative morbidity and mortality generally. It also reduces hypercoagulable state associated with surgery. All right, and that in any way also improve blood flow and also reduces the incidence of VTE. It decreases perioperative bleeding, all right, and by implication reduces the requirement for transfusion of blood or blood products, reduces the length of stay in the hospital by patients, increases early return of GI functions following surgery by also increasing blood flow to the mucosas, the GI mucosas. And lastly on this slide, Neuraxial block reduces the requirement for opioid use for postoperative analgesia, or we can say that Neuraxial blocks do have opioid sparing effects. And when you reduce the requirement for opioid, you also reduce the side effects associated with opioid use. Indications for Neuraxial blocks: all lower abdominal surgeries may be performed under Neuraxial block, except there are contraindications to the block itself. All lower extremity procedures, lumbar spinal surgeries, urogenital surgeries, and rectal surgeries, all these surgeries are amenable to Neuraxial blocks. Contraindications to Neuraxial blocks, I put something here. We could have absolute, relative, and controversial contraindications. Absolute contraindications, relative contraindications, and some controversial Neuraxial block. Contraindications. But I like mnemonics. I put all of that under what I call champions. So if I ask you to list the contraindications to Neuraxial blocks, these are the things I want. You can either categorize it under absolute, relative, or you can just give me all of this. All right. So champions, the C there refers to coagulopathy, hypovolemia, aortic stenosis, or mitral stenosis. Aortic stenosis and mitral stenosis come under what we call the fixed cardiac output state. Fixed cardiac output state. Patient refusal, intracranial hypertension. Others, patients who are uncooperative, patients with pre-existing neurological deficit, and patients with sepsis. Under absolute, infection at the site of your spinal injection, patient's refusal, coagulopathy, or other bleeding diathesis, and there have been some controversies that whether coagulopathy should actually be absolute or relative. Severe hypovolemia, intracranial hypertension, and the fixed cardiac output states, severe aortic stenosis, and severe mitral stenosis. These are traditionally considered as absolute contraindications to neuraxial block. Relatives, contraindications, sepsis, uncooperative patient with pre-existing neurological deficit, demyelinating lesions, stenotic valvular heart lesions, left ventricular flow obstruction, and severe spinal deformity, maybe because of technical difficulties. All right, some controversial contraindications, viral back surgery, all right, complicated surgery, prolonged operation, major blood loss, maneuvers that can compromise respiration, since your patient is going to be awake and is not under controlled ventilatory support. All right, complications of neuraxial blocks, hunchback. Just remember hunchback. All right. H there stands for hypotension. U stands for urinary retention. N stands for neurological sequelae, such as arachidonitis, meningitis, caudal inguinal syndrome. You may even have peripheral nerve injuries. C refers to cardiovascular collapse from high or total spinal. H refers to hearing impairment, low frequency hearing impairment, which oftentimes is transient. If you've got time, there's a case report that is published, transient hearing loss following spinal anesthesia. All right. I authored it with some other colleagues. You may want to check it out. All right. Then headache, post-dural puncture headache, backache from direct needle trauma. All right. All those other common ones are shivering, post-operative nausea, vomiting, pruritus, and failed spinal. These are some of the other complications of neuraxial blocks. All right, generally speaking, there are three different methods of assessing the level of block of neuraxial anesthesia. You want to check the level of sensory block. You want to check for level of sympathectomy, and you want to check for the level of motor block. So commonly we use the pinprick method to assess for the level of sensory block. Then we can use skin temperature. You can use a cold cotton wood swab, all right, to assess for the level of sympathectomy. And the bromide scale is actually used to test for the level of motor block. And bromide scale is divided into three. You can say no block when the patient is able to flex the knees and the feet. Partial block is when the patient is able to flex the knees only. And when you have a complete motor block, the patient is unable to flex the knees and the feet. All right, so let's talk about spinal anesthesia generally. In 1899, August Beer was the first to demonstrate spinal anesthesia, and it has become a useful technique that is applicable to most surgical procedures below the umbilicus. All right, spinal anesthesia is actually a lumbar puncture. Many of us must have seen a lumbar puncture for CSF aspiration and MCS. So, but here we assess the lumbar space using a spinal needle, all right? Ranges from 22 to 26 G. We've had some 27 gauge needles. All right, after you have confirmed, we're going to look at that you are in the subarachnoid space. How do you confirm that? By a free flow of CSF, a free flow of continuous CSF. It shows that you're in the subarachnoid space, after which you deposit your local anesthetic agent. All right. The CSF flow is actually as a result of puncturing the dura mater. Anatomy and physiology. It's important for you to understand the anatomy and physiology of the spine in order for you to do a proper neuraxial block. All right. So just for us to have remind ourselves of basic anatomy, the spine, if you look at it on the right side of the screen, all right, this is a picture from New York Society of Regional Anesthesia. All right, the spine comprises of 7 cervical vertebrae, 12 thoracic, 5 lumbar, and 5 fused cerebral sacral vertebral bones. All these vertebrae are joined together end to end with articulating joints and ligaments, and it houses the spinal cord canal. It houses the spinal cord in the spinal canal. So the vertebral bodies form the spinal canal where it houses the spinal cord. The spinal nerves exit the spinal canal via lateral spaces that are formed between the pedicles from adjacent vertebrae. You can see from all this one, this is where the spinal nerves exit from. All right, in between the vertebral bodies. You can see the slides, the arrows on the right side of the slide. And this is also important because when you're positioning your patient, you want to open the space in order for you to access the subarachnoid space. Note that spinal anesthesia is only performed in the lumbar area most of the times, and this is to avoid, causing any damage to the spinal cord, and also to prevent, injections, all right, in the upper and upper thoracic and the cervical regions, which could have catastrophic complications. On anatomy, the spinal cord ends in what we know as the conus medullaris. All right, that's where it ends, and most of the time it ends a little, around L2. But for the pediatric patient, it's a little more inferior, that extends to around L3. Suffice to note that there's no significant differences in the position of the conus medullaris between male and female sexes or with increasing age. The dural sac continues beyond the conus medullaris and it extends to the sacral segment S2, S3. All right, and for this reason, trying to inside the spinal needle, usually at L3 to L4 or L4, L5 interspace. When you choose any spinal space below this, all right, or above this rather, you're likely going to have spinal cord trauma, all right, especially in patients who are obese. All right, on entering, starting from the scale from posterior to anterior, there are different levels of structures you will encounter. All right, so if you're starting in the midline approach, you start posteriorly, you first assess the skin, which will require a very strict aseptic technique. Then you transverse through the subcutaneous fat, supraspinous ligament, interspinous ligament, then the ligamental flavum. Then once you pierce the dura mater, you enter into the subarachnoid space, which is evidenced by a free flow of cerebrospinal fluid. Then you have the subdural space, arachnoid matter, and the subarachnoid space. So these are the structures. In an average build is about 6 centimeters from the skin posteriorly to the subarachnoid space. All right. Another reason why it's important for you to understand the anatomy and physiology of the spine is that it is important for you to understand the hematoma anatomy. And what does this do? It helps you to appreciate the level of block for your target structures. For instance, for lower abdominal surgeries, we're going to come through to this very soon. Actually, the incision usually made below theta, which is the level of the umbilicals. But you want to achieve a spinal block level as high as up to T4, all right, which is at the level of the nipple. This is important to prevent patient discomfort or pain during peritoneal tugging, all right, and a lot of times with uterine manipulation. And patients may complain of pulling on their inside, all right. Other corresponding dermatomal landmarks, like I said, the nipple is at the level of T4. And when you're assessing for your level of block, we want to at least attain T4 for all upper abdominal surgeries and cesarean deliveries. So I'm sure you must have seen the anesthetist in theater, all right, trying to determine the level of block. Once they get T4, they're happy because you apparently would prevent the patient from having any form of pain or any form of pulling, as they call it. All right, C8 is at the level of the fifth finger. All right, T7 is at the Seaford process, which a lot of times is adequate for appendectomy or other low abdominal surgeries. And T10 is for umbilicals. So a lot of times this is adequate for most lower limb extremity surgeries. All right, so in terms of anatomy and physiology, again, we're going to look at the order of spinal anesthesia. Once you inject your local anesthetic agent to the subarachnoid space, the first sympathetic fibers that are blocked are the small unmyelinated fibers. The small unmyelinated sympathetic fibers are the first to block, and after which the myelinated fibers are blocked, which transmit sensory and motor. All right, and sympathetic block are actually, and this is very important, the level of sympathetic block can actually exceed or be higher than motor and sensory block by 2 dermatones. So if you're having a sensory block at maybe let's say T6, your sympathetic block may be even as high as T4. And some authors even say it can be variable, it can be as high as 2 to 6 dermatones level above the level of your motor or sensory block. All right, don't forget that spinal anesthesia has little effect of ventilation, but high spinal can actually affect the patient's ability to cough. And sometimes the patient may complain of difficulty with breathing. All right. And this is just an indication of high spinal, and positioning your patient, giving the patient oxygen reassurance may do in this case. But anything above T5 inhibits sympathetic nerve supply to the GI tract. So you can have surgeries on the hip and, transurethral resection of the prostate, usually bleed less because of reduction in systemic pressure. And some of them may suffer less of VT, like we mentioned before, due to increased blood flow to the lower extremity. So when there's increased blood flow, the risk of thrombus developing and embolizing, all right, reduces because there's free flow, which spinal anesthesia, neuraxial blood usually has as an advantage.
Recording in progress.
Okay, so we'll do step-by-step block, spinal block. I like mnemonics, I'm sure you know now. If you want to do a spinal, you want to follow this, my step-by-step, I call it spinal. X, you want to select appropriate patient vis-a-vis the indications, all right, and ruler contraindications. This is important before you start. Do you have appropriate patient for appropriate technique and all that? Discussing with your surgeon, how far will your incision go? All right, as the patient given consent, all right, these are very important steps. Then secondly, after you have selected the appropriate patient for appropriate technique, you want to position the patient. all right, position the patient. We're going to look at different positions that are adopted for spinal anesthesia, but commonly the sitting position is what is commonly adopted in our centers and our settings. I know that some also do lateral, but for the sitting position, you want to position the patient seated with the feet on the stool with the back flexed. And you can actually do this by telling the patient to hug a pillow. All right. You want to identify the appropriate intervertebral space. And how do you do that? You use an imaginary line which passes through the top of the iliac crest, also known as the intercristing or Tufier's line. Okay. This line is an imaginary line. A lot of times for beginners, you can actually use your permanent marker to just draw a line passing through the iliac crest on both sides. And this line, once you get it a straight line, it crosses the body of the fourth lumbar vertebrae, the L4, all right? And then a lot of times it also corresponds to the interspace between L3 and L4. And needle insertion. After you identify the space you want to insert your needle, all right, in a professional controlled fashion. And how do you assess for correct placement of your needle is when you see a free flow, a backflow of cerebrospinal fluid, all right? It must be free flow, must be continuous, all right? After which you deposit the appropriate volume of your local anesthetic agent into the subarachnoid space. Sometimes we add adjuvants such as opioids or your vasoconstrictors like phenylephrine or epinephrine, all right, to increase the quality and the duration of your anesthesia. And after that, you need to lie the patient back to the supine position. And this is very important that you put a pillow behind the head in order to prevent excessive rostral spread of your local anesthetic agent. All right. And be careful when you're positioning the patient, all right, because too fast positioning or inappropriate positioning may actually affect the level of block. So after that, you want to confirm the level of block as we have described earlier on. Now, if you have any question, you can stop me. We have a lot, so I'm just trying to run through it. But if you do have a question, raise your hand. I will recognize you, then you can ask your question. But if not, we just run through this as we continue. What are the factors that affect the level of block? Number one, the baricity of your local anesthetic agent. All right, this is talking about specific gravity of your anesthetic agent relative to the plasma. All right. For instance, we have three different types of local anesthetic agents. We have hyperbaric. All right. We also call it heavy. All right. Hyperbaric propinfocaine. Also, I'm sure you must have heard about it, heavy McCain. All right. What is done here is that you add glucose to increase the specific gravity of the local anesthetic agent. All right. For hyperbaric solution, it follows gravity. It has greater cephalary spread if you position the patient, and it's normally dependent on the lumbar lordosis of the patient. All right. Hyperbaric is when you dilute your local anesthetic agent with sterile water and it spreads in a non-dependent fashion. And sometimes the choice of your local anesthetic agent will be determined by the surgery. For instance, if you want to do a unilateral limb procedure, you may want to use hyperbaric, all right, with the side of operation position on top. All right, isobaric clinically behaves as hyperbaric in most times. So the first factor that determines the level of block is your baricity. Second is the site of injection. If you're injecting your local anesthetic agent at a higher level, at a higher intervertebral level, you have a higher level of block. Positioning, which I mentioned before, during and immediately after the injection of your LA, will determine the level of blood. Age, elderly patients tend to have reduced CSF volume, and therefore they are prone to higher blocks, because especially if you have hyperbaric solution. Height, taller patients require more drugs, all right, to achieve a given level, because height is a determinant of the level of block. CSF volume, reduced CSF volume has inverse relationship with the level of block. Reduced CSF volume will increase the level of block. So in conditions of high intra-abdominal hypertension or increased intra-abdominal pressure, or conditions such as pregnancy, ascites, and large abdominal tumors, which cause engorgement of the epidural veins, all these things decrease the volume of CSF and therefore are associated with higher blocks. And that's why in obstetrics, in parturients, we use lower doses of local anesthetic agents to achieve our block. Additives I mentioned earlier, vasoconstrictors such as epinephrine, phenylephrine, cause tissue vasoconstriction, and by implication, they limit systemic reabsorption of local anesthetic agent, prolonging the duration of action, okay, of this agent. The dose, obviously, of local anesthetic agent and the needle direction, higher levels are achieved if you direct your spinal needle carefully, you produce higher blood. Others like the pH, all right, and that's why additives like sodium bicarbonate tend to favor more of the non-ionized lipid, lipophilic parts of the local anesthetic agent and cause more diffusion, all right, into the cerebrospinal fluid, causing higher blocks. All right, I put this here, all right. If you are asked what are the factors that affect the level of block, you either go the way I mentioned it, or you want to look at it based on the properties of local anesthetic solution, patient's characteristics, and the technique of the block. All right. Properties of local anesthetic agent comprises of the basicity of the agent, the dose, the volume, specific gravity. Patient characteristics, position during and after, height, extremely short or tall, spinal column anatomy, all right, decreased CSF volume, like I mentioned. Technique, site of injection, and the direction of your needle. There are different positioning for local anesthetic agent, and I'm going to put there, all right, for us to know. So we can see this is sitting position, all right. This is the iliac crest I mentioned before. So when you draw a line, all right, an imaginary line, all right, passing through the iliac crest, all right, the top of the iliac crest, you cross the body of L4, or you are in the L4, L5, or L3, L4 interspace, all right? You draw a line. This is the intercristal line. You can see from my arrow, all right? The iliac crest on both sides, the line passes between L3, L4 interspace, or the body of L4. All right, you can have your patient in lateral position, all right? The way the patient is hugged this way, and the hip is raised vertical, the knees are drawn up to the chest, and the shoulders remain vertical, all right? With this, you may be able to assess. And for patients who may not be able to sit down, for patients with hip fracture, or patients with femoral fracture that are difficult to sit down, you may be able to assess the subarachnoid space, therefore performing your spinal in lateral position. All right, this is the diagram that I have here. All right, then let me see. So there are different forms, like I mentioned before. We have sitting position, then we have the modified sitting position. In the modified sitting position, the patient sits up from the supine position with the legs remaining on the table. The traditional sitting position, the leg must be on a stool, all right? But in modified sitting position, why that a lot of practitioners do now, the patient rises up from the supine position and sits up, but the legs remain on the operating table. All right, lateral decubitus position, I've described that before. All right, prone position may also be used to perform spinal anesthesia. All right, and in here, you want to use a hyperbaric or isobaric solution, all right, for spinal procedures in the prone position. I've mentioned this to you before. So types of spinal needles. Spinal needles are classified according to the type. We have the cutting tip, all right, this is a cutting tip. You can see the tip is cutting tip, or the Quinken needles. What they do, they have sharp cutting tips with a hole at the end of the needle. Then we have the pencil point, or the non-cutting. Examples are the winter care, you can see here, or the sprouting needles. They have a hole by the side, not at the end. For the cutting tip of Quinken needle, the hole is at the end, while for the pencil point or the non-cutting needles, the winter care and the sprouting, they are at the side. You can see it here. And there are a lot of different, there are reasons. There is a lot of times, we're going to come to that, especially when we're talking about post-dural puncture headache, all right, where the risk factors, the determining factors have to do with both the size and the type of the needle. Larger size, greater like 22G needles are associated with more incidence of post-dural puncture headache, and Quinke or cutting needle with the end injection point at the end of the needle also increases the incidence or the risk of post-dural puncture headache. So for especially obstetric patient or patient who are at risk of developing post-dural puncture headache, we prefer the non-cutting pencil point spinal needles. All right, you need to monitor your spinal block. All right, the first 10 to 10 minutes are critical in terms of monitoring your cardiovascular response, as well as the level of sensory block. For this reason, traditionally, we monitor the blood pressure every minute for the first 5 to 10 minutes. All right, when we are satisfied of hemodynamic stability, we therefore monitor hence for every 5 minutes afterwards. Note that temperature changes are the first to go because they are served by the small unmyelinated sympathetic fibers. All right, and it's important. I'm sure most of the times you have seen that the anesthetics comes with either a wet alcohol swab or they carry a very cold, what they call it, a container. All right, and they begin to test for loss of temperature. You ask the patient, is it warm, is it cold, and it's important. It's faster because the first to go, and we normally do it so that it allows us time to allows us time to position the patient in case of any problems. All right. So sensory level, like I mentioned before, is tested with the aid of pinprick, and I've mentioned all of this to you before. The dermatomal level as per the level of surgery. So any question on spinal before we go to epidural? Any question? Today we are fair, we are 40. That's good. Any question before I run through epidural? Mary Kay.
Yes,
Dolly.
doctor, no questions.
No question, great.
Thank you,
Gallo?
doctor.
You're welcome. Gallo Wenshihange. Any question? Okay, great. But so you guys are following?
Yes, thank you, doctor.
Okay. So epidural block, we're going to look at epidural block. All right, like I told you, neuraxial block comprises of spinal, epidural, and caudal. All right. The technique of epidural block is similar to that of spinal block with some differences. All right. With the patient in the sitting lateral decubitus position, you put an epidural needle at the appropriate intervertebral space. and you assess the epidural space. Note that contrary to the confirmation of correct placement for spinal is free flow of cerebrospinal fluid, while the correct placement, confirmation of correct placement of the epidural needle is with loss of resistance, or what we call the hanging drop technique. You go gradually and you feel a give, then you feel a loss of resistance. It's obvious. It comes with technique, and you can feel it. Once you feel it, you stop and you perform what they call a hanging drop technique, where you put a drop of saline at the hub of your epidural needle. Because of the negative pressure, that drop of saline is soaked into the epidural needle. So that's how we confirm for correct placement of your epidural needle. Now, after confirmation, you can actually do a single shot, or you can pass a epidural catheter, which can use for continuous top-up of your local anesthetic agent. Okay. Physiology of epidural block. The major site of action for epidural block is the nerve roots. All right. And we have some diffusion of your local anesthetic into the subarachnoid space, producing some analgesia. Now, note that the most important physiological alteration that is as commonly associated with an epidural as well as spinal block is the sympathetic block. All right. Know that the T1 to T4 supply the cardiac accelerator centers, so they are known as cardiac accelerator fibers, and which control heart rate and contractility. And when you block this, you render your patient vulnerable to excessive vagal reflexes, which can produce sinus arrest. And that is why it's important for you to properly monitor your level of block. Once you are getting between T1 and T2 block, be careful, because vagal responses like rectal manipulation, and all that can actually lead to a sinus cardiac arrest on the table. I mentioned this before. Sympathetic nervous system block has several advantages. It increases blood flow to the mucosa blood flow, and increases bowel peristalsis. And this is one of the advantages that Neuraxial block has, because it enhances return of GI function upon surgery. It also favorably alters myocardial oxygen supply, reduces ischemic event, and it's been found to improve functional recovery after myocardial stunning in dogs. All right, sympathectomy induced hypotension can actually reduce surgical bleeding. Okay, but be careful that it's not too excessive, because it can lead to various infarction. All right, epidural blocks have been also found to have favorable effects on pulmonary function, because it helps prevent splinting of the diaphragm, and helps to maintain the ability to cough and deep breathe in the patient. I mentioned this before. Epidural block can actually be achieved either using a single shot technique or a continuous epidural technique. A single shot technique, you want to do two things. Don't forget that. Number one, you want to ensure there's a negative aspiration. You don't want CSF and you don't want blood. All right, because the volume we use in epidural is much, much higher than that we use for spinal. So you can imagine if you deposit 20 mils or 40 mils, sometimes we give as high as 20 to 40 mils or local anesthetic agent in epidural space, because it's larger. You can imagine giving that high volume into your subarachnoid space, you're going to have cardiac arrest. Everything is going, total spinal will ensue. So you want to perform negative aspiration vis-a-vis there's no CSF, then there's no blood. So negative aspiration and a test dose of your 3 ml of 1% lidocaine with 1 in 200% epinephrine. All right, and the test dose is to show that you are not in the intravascular space, because you don't want to give that large volume of local anesthetic agent into the intravascular space. All right, this is important. You know, even when you are doing the continuous epidural technique, after inserting your catheter, and when you're putting your catheter, you just want about 3 to 5 cm beyond the needle tip. All right, because you don't want to go further. All right, so that you don't enter a vein and you don't want to come out of the intervertebral foramen, or you don't want your catheter to be wrapped around the nerve root. Know that after you have inserted your epidural catheter, don't try to bring it back. Don't try to remove it back through the needle, because it might actually cause a needle transection. Like we said, you want to give a test dose, and you want to have a negative aspiration, just like in your single shot technique. All right, level and duration of epidural block. Listen, this is important. It has some slight differences compared to that of spinal. All right, in most of the times we reduce the concentration. Instead of giving 0.5%, we give 0.25. Sometimes we give 0.125, especially in pediatrics, in obstetrics, where we have what we call walking epidural. So you reduce the concentration, but you increase the volume. All right, and this aids in increasing the spread of your local anesthetic solution. Lumbar epidural tends to flow cephalide. All right, this is due to negative intrathoracic pressure. But when you are given thoracic epidurals, the local anesthetic solution tends to stay where you injected it. All right. Performing lumbar epidural L5-S1 is more difficult because of the larger fiber size of in this location. And note that in epidural, baricity does not have much role as opposed to in spinal anesthesia in terms of the level of block and body position, or it's also less important. The choice of local anesthetic agent depends on what you want to achieve. You know, for short procedures, chloroquine is being used because it has a fast onset of action. All right, it's intermediate, but bupivacaine has lower onset of action but prolonged duration of action. For purpose of single best answer questions, note that tetracaine and proclaim are no longer used because of their long latency times. Epidural adjuvant medications, like we mentioned before, epinephrine, opioids, and bicarbonate. Suffice to say here that when you add epinephrine, 5 units, all right, per mil, that is 1 in 200,000 epinephrine, you can actually prolong the duration of action of epidural, all right? But note that it is not, the effect is not pronounced with bupivacaine, but for lidocaine and chloroquine, yes. So epinephrine does not have impact, so much impact on prolonging the duration of action of bupivacaine, all right? Opioids can enhance your analgesia, and sometimes we add opioids, fentanyl, morphine, and all that. All right, so I look at anesthetic agent to prolong a duration of analgesia. All right, but beware of their side effects like pruritus and all that. All right. Note that morphine, which is hydrophilic, lipophobic, all right, they stay in place or spread rostrally, whereas fentanyl will be rapidly absorbed. Bicarbonate as an adjunct favors the non-ionized form of your local anesthetic agent and may promote more rapid onset of epidural anesthesia. Don't forget, when we're talking about local anesthetic agent, we did mention factors that can increase onset of action of local anesthetic agents. And additives or adjuvants like bicarbonate was mentioned if you were in that tutorial. Epidural needle, we do spinal anesthesia with spinal needle, epidural anesthesia with epidural needle, and there are different types. We have the Crawford, the Tuohy needle, the Holstead, and the Wyss needle. All right, and you have the diagrams on this side of the screen. The common ones we use is the Tobi needle. This is the second one. And it's actually a very large needle compared to your spinal needle. It's about between 17 to 18 G needle. It has a blunt bevel, so to reduce the risk of causing the dura tear. All right, because you don't want to pierce the dura. All right, you don't want CSM. So it has a blunt bevel. You can see it with a gentle curve of about 15 to 30 degrees at the tip. So with this, you reduce the risk of accidental or unintentional dura puncture. It does this by helping to put the dura away after passing the ligamental flavum instead of penetrating it. The Crawford needle is straighter without a curved tube. Therefore, it has a high incidence of dura puncture. But the advantage of the Crawford epidural needle is that it allows easier access or easier passage of your epidural catheter. You can see here sometimes passing your epidural catheter becomes difficult. You need some technical expertise for your catheter to pass through the Tobi needle. Post-dural puncture headache is headache following spinal or accidental dural puncture. All right. For patients, all right, whose dura is accidentally punctured, they have as far as 50% risk of post-dural puncture headache. All right. I mentioned to you before that the type in terms of spinal needle, epidural needle, will determine the incidence of post-dural puncture headache. So large 22G Quincke needle can produce post-dural puncture headache in about 30 to 70% of cases. That is 1 in 3 to 1 in 7 of all your patients. And that's why we do not recommend large gauge needle, Quincke needle. Don't forget that it's large, and 2 is also a cutting needle. So the incidence of post-dural puncture headache is about 30 to 70%. Whereas the smaller gauge needle, 24 to 25 or even 27 gauge needle, we have an incidence of post-dural puncture headache as low as 3 to 5%. Don't forget that the smaller the needle, all right, you may need an introducer because it's difficult to pierce the skin and all the structures you want to transverse in order to get to your subaqueous space. But with an introducer, it helps because introducer does not go beyond the subcutaneous tissue to help you to transverse that. All right. The risk factors of post-dural puncture headache include, like I mentioned before, the bevel, Quincke needle. So we prefer pencil point needles, larger needles, female gender, pregnant state, younger age, and patients who have previous history of post-dural puncture headache. Now take note of this, differences between spinal and epidural anesthesia. All right. Epidural technique offers a wider range of application than spinal anesthesia. We mentioned before, commonly spinal anesthesia is performed at the lumbar, but for epidural, you can actually do cervical throughout the spine. Cervical, you can do thoracic, you can do lumbar, you can do, what is there? You can do caudal, all right, sacral root. So it has a wider variation of application, all right. The wider variation, you can use it for post-op analgesia. A lot of times the catheters are left in situ, all right, and they're taken to the ward or high care unit, okay. A lot of times you can even use for chronic pain management. It can be done as a single shot technique or with a catheter, all right. And you can have very different levels of motor block depending on the concentration of your local anesthetic agent. Like I mentioned before, the walking epidural. Note also that epidural block is less predictable than spinal anesthesia. Yeah, caudal block. All right, these patients can either be in prone or lateral decubitus position, and we do a lot of caudal in children. And a 22G needle is inserted at 45 degrees to the skin overlying the sacral hiatus. All right, the sacral hiatus lies about 5 centimeters above the tip of the coccyx. That is the end of the spinal canal, all right, the vertebrae, all right. So correct placement of the needle of the tube is confirmed by injecting 10 ml of air through the needle. Some people have, some authors don't like this, all right, we call it air whoosh. The fingers of the other hand are used to palpate the subcutaneous tissue over the sacrum. And if the needle is too superficial, you will obviously feel subcutaneous crepitation. All right. And sometimes you move your caudal needle, lateral, right, to the right or the left, and you can actually feel the bony structures to confirm that you're in the space. Obviously, you want to aspirate to ensure that there are no CSF, all right, and you are not in any vessel. After a correct placement, about 20 to 25 ml of anesthetic agent is deposited into the space, which corresponds to the volume of the sacral canal. There are different volumes that can be injected into the caudal space, and different regimen has been used, and it corresponds to the dermatomal block you want to achieve. For the sacral dermatome, you want to give 0.5 ml per kg. All right, for lumbar dermatomal level, 1 ml per kg. And for mid-thoracic dermatomal level, you can actually increase your volume to about 1.25 ml per kg. This is what we know as the Armitage regimen. Armitage regimen. What are the complications of caudal block? Like mnemonics. So we use CAUDA as the mnemonics for complications of caudal block. All right, cardiovascular depression, which comes with hypertension. You can have antisacral injection with perforation of this rectum, urinary retention. You can have delayed respiratory depression, and that's why the patients are usually nursed and observed in the recovery room before the patient is transferred to the open ward. You can actually have accidental subdural, intravascular, or intraosseous injection of your local anesthetic agent. And you can have a local anesthetic toxicity. We mentioned it in our lecture under local anesthetic agent. Others are infection, injury to nerve roots, hematoma formation, and sacral osteomyelitis. Yes, we have successfully navigated to the end of the lecture. Any question, people? Any question before I ask? Okay, let's go. Let's answer these questions now. Anybody want to answer first question? Read this question, single best answer, and answer it quickly. Anyone? Vikas, are you here?
I am here, doctor.
Okay, read first question and answer it, then call somebody to read second question and answer it.
Okay, so the first question is, the following are absolute contraindications to neuraxial blocks, except A, coagulopathy, B, hypovolemia, C, aortic stenosis, D, patient refusal, and E, previous stroke.
What's the answer?
I believe the answer to be C, aortic stenosis.
I beg to differ. We said that we said fixed cardiac output state is an absolute contraindication, isn't it? And fixed cardiac output state talks about aortic stenosis and mitral stenosis. You want to change your mind?
Yeah, sorry, doctor. I wasn't here for the first part of the presentation, so I can't give you the correct answer.
Okay. Mention somebody. Mary Kay, help your brother out.
Doctor, I think it might be B, hypovolemia.
No, hey guys, they follow my lecture today. Hypovolemia is a absolute contraindication. Oh my God, let's quickly go there. My heart, you guys broke my heart.
Doctor, the answer is C.
My heart has been broken. You guys broke my heart.
Apologies, Doctor. In the beginning, we were still coordinating ourselves.
Okay.
We both missed the beginning.
Mary Kay, read this. What are the contraindications to the anaesthesia block?
Okay, so the mnemonics champions, so coagulopathy, hypovolemia, aortic stenosis, and mitral stenosis, patient refusal, intracranial pressure increases, and then others like an uncooperative patient, neurological deficits, and sepsis. So the
Now,
answer
if you go to the other side, what are the absolute contraindications?
Infections at the site of injection, patient refusal, coagulopathy or other bleeding disorders, or diathesis, and then severe hypovolemia, increased intracranial pressure, severe aortic stenosis, or severe mitral stenosis.
So what would be your answer? Let's go back to the question.
It would be previous stroke, which I think was the last one.
Yes, correct. All right. Because you agree now.
Yes, Doctor, I agree. Thank you.
Okay. Who are the people? Dolly, answer. Read question 2 and answer it. Is Dolly there?
Yes, Doctor. Yes.
Okay, read question 2 and answer.
Which of the following differences between spinal and epidural anesthesia is not correct? Doc, must I read all of them or must I just say which
Choose
one?
answer. Choose answer. No problem.
E.
E, correct.
Epidural is more predictable.
It's not correct. That's your correct answer. Correct. All right. Because epidural block is less predictable. Correct. Who again is there? Ganon. I remembered some names. Ganon, read question 3 and answer for me. Is Ganon there? Victor Kajimi. Victor.
Doctor, can I answer it?
Yes, please identify yourself.
The following are examples.
Identify yourself, my dear.
Linear.
Linear. Okay, L after L. Linear. Okay.
The following are examples of epidural needles except the sprout needle.
Beautiful. Correct. Correct. Sprout needle. Sprout needle is a pencil point spinal needle, isn't it? Correct. Let's see. Do I still have more questions? Oh, unfortunately, that's the end. Any question? Are you happy? Are you ready for my test on Monday?
We are trying, Doctor.